Rob, it's all yours.
Okay, well, thank you so much. What a great pleasure for me to be here. Thank you so much for inviting us to be with you this morning. This is a remarkable year in New Mexico. It's certainly a remarkable year for end-of-life care, and it is in large part due to the actions of this organization and your lobbyist, who was a very thoughtful presenter to the legislature on the advantages and the disadvantages of medical aid in dying. So Ms. Siegel was presented information that the legislature needed to have, first, to create medical aid in dying and permit medical aid in dying in New Mexico, and second, to make sure that advanced practice nurses were included as providers in that statute. There are a dozen states and jurisdictions in the United States that allow for medical aid in dying now. New Mexico is the only one where nurse practitioners and PAs are permitted, are treated as any other medical practitioners, MDs and DOs, for purposes of the statute. So New Mexico is leading the nation in that respect, and again, it's because of the information that was provided by this organization in part, and because of the leadership that the nursing profession as a whole has provided to the development of health and health law in New Mexico. It's a special relationship in New Mexico, and I know that you have a wonderful relationship with each other, and that's why I hope someone will take that lady to lunch today, because she didn't sleep last night, and no one took her to lunch yesterday, and she's very engaging, so it'll be a wonderful opportunity. What I intend to do is just give you a little background on how we came to have the Elizabeth Whitefield End-of-Life Options Act in New Mexico, and then Hunter is going to take you through it and suggest how you would deal with a patient who's interested in the kind of care that's authorized by that act. And let me just begin by reminding you, as I look out at this group, there were very few of you who remember what health care was like in the 1960s and 1970s. Some of us actually remember this. Some of us were teaching it back in the 1960s and 1970s. And if there's one ethical principle that was prominent, it was that the goal of the healthcare system was to save lives. That was the first goal, that was the primary goal, that was the only goal. You never crossed that value, which was to save lives. And in the 1960s and the 1970s, things began to change, because all of a sudden it wasn't necessarily the best action that you could take to save lives. And it's in part because of the it's entirely, in fact, because of the advances in medicine. And you think about, this is the time when the quality of dialysis improved dramatically, when the transplant technology improved dramatically, when ventilators improved all of a sudden, when tube feeding became much more efficient and much better, higher quality than it had been before. And all of a sudden, there were people who were kept alive who might not have wanted to be kept alive. That, in fact, the people could be, at least patients, those of us who were not healthcare providers, became worried, not that we were going to die before a healthcare provider could get to us, but that we might be kept alive forever, at least indefinitely, because of the care that would be offered, and that finally, for the first time in the history of medicine, actually could be offered. And that led to an ethical revolution about what the goals of healthcare really should be, and also to legal changes. And let me just quickly take you through the legal changes. You know, it was in the 1970s, we weren't sure yet whether it was legal ever to remove life-sustaining medical treatment. And some of you probably heard of the Quinlan case, and very few of you were around for the Quinlan case. But Karen Ann Quinlan, who was in at least near persistent vegetative state, the argument was, in a nursing home in Pennsylvania after a drug and alcohol overdose, and her parents wanted to remove some life-sustaining medical treatment that she was being provided. And no one knew if she could do it, and the district attorney in Pennsylvania said you couldn't. Anyone who removed that care, anyone would be guilty of a crime, would be guilty of murder, because, in fact, she wasn't there to make the decision, and there was nothing in law that authorized anybody else to make the decision. And the worry was that she was going to have to remain in that position forever. Now, In fact, that went to the courts in New Jersey, and eventually, it took a while, the New Jersey Supreme Court said, yes, the parents had the authority to remove that kind of care under circumstances like this because they had the authority to make health care decisions for her. But it was the first time that a court had said that in the United States. And it was followed by still more litigation, the Cruzan case, which some of you might remember. Nancy Cruzan, who was injured in a one-car accident in Missouri, was in persistent vegetative state. She was in a nursing home in Missouri. Her parents said she would never have wanted this. There was no hope of any recovery. She had brainstem function, but nothing else, no other brain function. And her parents and her close friends all said she would never want this. This would be hell for her. And it's important that she be disconnected. The state of Missouri said, well, we set the rules, and our rule is that you cannot discontinue life-sustaining care unless you have clear and convincing evidence from the mouth of the patient that the patient wouldn't want this. You know, does that ever happen? No, that rarely happens, at least. And so, at first, it was impossible to remove that treatment. About 5 years later, the politics of the case changed, and her parents came back, and they had found friends who said that Cruzan had actually said discontinue treatment, and the court finally allowed that treatment to be discontinued. But around the country, people began to wonder, began to think there's something wrong with the law that would lead to that. And it led to a recommendation for states across the country to adopt the Uniform Health Care Decisions Act. And the next year, in the mid-1990s, New Mexico became the first state to adopt the Uniform Health Care Decisions Act. And it's the first time a state legislature said that, in fact, first, a patient has the right to accept or forego any medical treatment, period. Any medical treatment. So if a patient's competent, a patient can undergo the treatment or decide not to undergo the treatment. Anything, including tube feeding and ventilator care and life-sustaining treatment or anything else. And second, if in fact that patient can't decide, there's a process for determining who gets to make the decision for the patient. And that decision can be made based on what the patient would actually decide. And it was a really important date in New Mexico when the legislature here adopted the Uniform Health Care Decisions Act, and other states followed. New Mexico changed it a bit, and other states adopted the New Mexico changes. So the law that we have on decisions in New Mexico is a law across the country, and it was effective in giving patients authority they didn't have before, but it still didn't deal with one class of cases. That is where the patient was suffering or leading a life that the patient didn't find to be a satisfying life, a terminally ill patient who could foresee the suffering that was ahead, but wasn't on life-sustaining medical treatment. A patient who simply was dying of a disease and where palliative care was not going to be adequate in the mind of the patient. And the question was what to do in those cases. And when New Mexico was adopting the Uniform Health Care Decisions Act, becoming the first state to do so, other states, well, one or two other states were looking elsewhere. Actually, the first state with a proposal for a medical aid in dying was New Mexico in the 1980s. It took a long time for New Mexico to get around to passing it. Oregon passed it in the 1990s, becoming the first state to allow medical aid in dying, to allow an affirmative act that caused the death of the patient under very limited circumstances, which Hunter is going to describe to you in just a minute. But the Oregon law took 3 or 4 years to become effective in Oregon because of legal challenges to the existence of the law. And you know, it turned out to be really quite effective. It was really important for the patients who actually went through that. I'm just going to grab my notes here if I can from behind you. Other states began to think about following the Oregon lead, and it finally, the bill was introduced in New Mexico every 2 years, every general legislative session from the 1990s, actually from the 1980s. Senator Liz Stefanik, who introduced the bill that passed, also introduced the bill in 1986. She subsequently lost her re-election campaign, left the legislature, years later came back to the legislature, introduced the bill again with the time that it finally passed. And as I think you know, and as Hunter's going to talk about in much greater detail, the law provides that any competent, terminally ill adult in New Mexico who is acting voluntarily can request that a healthcare provider write a prescription for a lethal dose. And that is the foundation, that is the centerpiece of medical aid in dying, and that is the centerpiece of the End of Life Options Act in New Mexico. So the act protects all terminally ill patients, and it also protects all providers, because the law has a very strong conscience clause that will apply to you. Nobody is required to participate. Nobody can be forbidden from participating either. And that's a New Mexico development. Other states say no one can be required to participate. In New Mexico, no one can be required to participate, but no one can be forbidden to participate either. And the hard question in New Mexico was writing the conscience clause that recognized the conscience of the individual, your conscience, to decide whether to participate or not, and also recognizing the conscience, to the extent there is one, of the healthcare institution. Because, in fact, many of the healthcare institutions are religious institutions. They have values that may not permit medical aid in dying. And the question is, what happens if you're providing care at one of those institutions? And in most states, the institution can put anything they want in a contract, and you're bound by that contract. In New Mexico, the institution can tell you what you can't do on the grounds of the institution when you're on the clock for that institution. But when you're off the grounds, and when you're off the clock, or when you're off the clock, you can follow your own conscience and do whatever you think would be otherwise appropriate. And so that's a pretty significant difference between New Mexico and other states. Let me just mention the other significant differences, because there are some, and I'm sure Hunter will cover them in greater detail, but the first that I want to mention is that, of course, advanced practice nurses and PAs are providers in New Mexico. That's true, I mean, for many of us who've been working in health law for years, the idea is to get advanced practice nurses and PAs listed as many places as we possibly can to increase the scope of practice, because obviously whenever the scope of practice has been enlarged, that has been successful in New Mexico. Every single time it's been enlarged, it's been successful in New Mexico, and many states have followed the New Mexico lead there too, to recognize a larger scope of practice. But there also are procedural differences in New Mexico, because we learn from other states. One of them is that the waiting period between when a prescription, a lethal dose, is written and when it can be taken is normally 15 days. In fact, in most states, you must request the lethal dose, and then the prescription can't be written for 15 days. In New Mexico, the waiting time is 48 hours, and the 48 hours can be waived if the provider believes that, in fact, the patient's at risk of dying during that 48 hours. So it's a very different approach than elsewhere. And you look at California, which is a place where I've studied the way the law is effective, and there's a 15-day waiting period, but because you need 2 providers to support all the findings that the patient is terminally ill, that the patient is acting voluntarily, it takes 45 days to actually go through the process. And an awful lot of people, most people don't think about this until they're near death. They're suffering near death, and in fact that turns out to make it impossible for most people to use the law. And so in New Mexico we have a very different standard, and the 48-hour standard, and the 48-hour standard has been waived in some cases already. The first year that the law will be in effect will be June 18th. It went into effect last June 18th. So that is a substantial change in the law. And the other significant change in New Mexico is that the second healthcare provider, in every state there has to be a second healthcare provider who confirms everything the first one said. In New Mexico, you don't need the second provider if the patient is on hospice. And since almost everybody who makes this choice is on hospice, in other states it's about 90%, and that same 90% seems to be holding up in New Mexico. Since everybody's on hospice, this is treated like any other health care. And the goal is to normalize and rationalize this so that it is maybe an unusual procedure. Not very many people are going to choose medical aid in dying, but to make sure that those who do actually have access to medical aid in dying. There's one other unrelated part of the law, not completely unrelated, that I just wanted to mention, and that is the right to know law. In New Mexico, terminally ill patients must be informed about all reasonable medical options for them. So that means that terminally ill patients must be informed about the existence of medical aid in dying. You don't have to provide it. You may choose not to provide it, but you must inform patients about it. And in addition, if the patient chooses it, you must do what you can to connect the patient to someone who will help the patient to get access to that care. So nobody is forced, nobody is required to participate, but every patient has to know the actual options available to the patient in New Mexico. That a right to know law becomes part of informed consent law then in New Mexico. So it's a new world now with medical aid in dying and end-of-life care. It's available in rural New Mexico and in most of urban New Mexico too, underserved New Mexico, because of the availability of many more practitioners who can in fact engage in what you're trained to do in actually carrying out this law. And I hope that you will at least think about the implications for the law in two different ways. One, under the right to know law, your obligations to provide the information to the patient so the patient can make the decision consistent with the patient's values. And second, so that you can actually provide these services where it seems appropriate. Thanks. Hunter? And we'll be available for questions as soon as, for the last 10, 15 minutes, I think, of the presentation too. Yeah.
All right, so I'm going to be a little bit tied to this podium because the clicker thing is not working, so I'll try to pop out and then come back in. But I'm Hunter, a registered nurse, and a recent F&P graduate waiting to sit for boards, and I'll be talking about kind of expounding upon what Rob just talked about. So we can jump into what we will cover, and I'm going to try to cover it quickly to leave time for questions at the end, so I'll be moving fast. Thanks for understanding. So we'll talk about what exactly medical aid in dying is, and you'll also hear me refer to it as MAID throughout the presentation, just for brevity. So if I say MAID, I'm referring to medical aid in dying, which used to be kind of referred to as death with dignity, which we will talk about as well. So we'll talk about who is eligible, what patients we work with are eligible for medical aid in dying. Rob touched on that a little bit. We'll talk about the legal requirements and paperwork requirements for providers in New Mexico. And since we are NPs, I will talk about the requirements for NPs specifically. Oh yeah, for sure. Just keep doing the thing? Okay, cool. So we'll get into pharmacology, what these medications actually are, ingestion, potential risks with ingestion, and red flags, some clinical signs that can, I guess, raise flags for us to make us concerned that there could be a prolonged death. And then lastly, we'll go over resources for clinicians such as yourselves, as well as for those who are terminally ill. Okay, so I don't have any disclosures. I'm an unpaid volunteer with End of Life Options New Mexico who has a booth out there actually if you're wanting any literature, anything else after this. So before we talk about what medical aid in dying is, we're going to talk about what medical aid in dying is not. So medical aid in dying is not assisted suicide. That is not me just saying that. It is clinically distinct and legally distinct from assisted suicide. So within the law, this is a quote from the law, distinguishing MAID from assisted suicide. So, quote, actions taken in accordance with the Elizabeth Whitefield End-of-Life Options Act shall not be construed for any purpose to constitute suicide, assisted suicide, euthanasia, mercy killing, homicide, or adult abuse under the law. Additionally, organizations such as the American Academy of Hospice and Palliative Medicine, the American Public Health Association, and others have all adopted policies opposing the use of the word suicide when referring to medical aid in dying. And honestly, for me, with all due respect, Rob, I could care less what legal experts say, what like clinical organizations say this is. Patients who use this law also feel like this is very, very distinct from suicide. So this is a quote from Brittany Maynard, who was a California resident who advocated for passage of legislation there. So she said, there's a difference between a person who is dying and a person who is suicidal. I am dying in the way that my brain cancer would take me is terrible. So she ended up passing peacefully using aid in dying legislation in Oregon several years back at the age of 29. So euthanasia, you might remember this person, Dr. Kevorkian, affectionately referred to as Dr. Death. So euthanasia, by definition, is administering a medication to another individual with the intention of causing death, or like mercy killing would be another term. Within the New Mexico law, it requires that patients ingest the medication themselves, so that is a significant distinction between euthanasia. Euthanasia was illegal, remains illegal, is illegal under New Mexico state law, as well as every other law in the United States. What Dr. Kevorkian was convicted of murder for was administering a lethal dose of a medication to an individual with ALS. While he did it at the direction of that individual, that still remains illegal under New Mexico law as well as everywhere else. So can't be any more clear that like this legislation is not euthanasia. And death with dignity, so that used to be the preferred term for some time. States like Oregon and Washington use that language. But as we all know, dignity is subjective. Dignity, whether it is dignity in life or dignity in death, is defined by the patients that we work with. So to imply that MAID deaths inherently have more dignity than another is not a good way to go. It may for some people, it may not for others. So for just the preferred language and the best language to use when referring to this is MAID or medical aid in dying. Hold on. So we talked about what it is not. So now we'll talk about what medical aid in dying is. So medical aid in dying allows, as you can see, a terminally ill, mentally competent adult resident of New Mexico acting voluntarily request a provider write them a prescription for a medication which, when self-administered, results in death. So we're going to kind of break this down, the definition of each piece. So terminally ill means that they have a prognosis of 6 months or less, confirmed by 2 providers. The exception being if they are on hospice by the standard of care, a physician has already signed a certificate of terminal illness showing that they have a prognosis of 6 months or less. So competent means that there is no concern for mental illness, dementia, other concerns. There's no requirement for another individual to establish that this patient is competent. If you have concerns, though, there are, within the law, a psychiatrist, psychologist, social worker, psych NP, or professional clinical mental health counselor can complete a mental health evaluation to determine competency. Again, that's not required. That is only in cases in which you are uncertain within your role if an individual indeed has competency to make this decision. And I'll touch on this throughout the presentation, but as we all know, particularly with diseases like cancer, other things, competency changes. How lucid a patient is changes. So if you're working with somebody who's pursuing this, it's imperative to continually assess their mental status and the fact and their just how oriented they are to what the implications of ingesting a medication like this would be. So acting voluntarily means that folks aren't coerced for any reason. Residency means there's no definition of what residency of New Mexico is in the law. If you have any specific questions about that, I would encourage going and asking at the table afterwards. Myself or Rob would be happy to answer that a little bit more. But it doesn't mean you have to have like a New Mexico driver's license, for instance. And provider, we talked about New Mexico is unique in that it allows physician assistants, nurse practitioners to prescribe. And self-administration we'll talk about a little more later, but again, people need to be able to ingest medication themselves. Somebody else giving it to them is illegal, remains illegal, always has been illegal. That is euthanasia, that is not this. So thinking about who this leaves out, folks with dementia do not qualify for this law. Another disease process that is important just to consider is ALS and progressive neuromuscular diseases. So somebody might be eligible at one point, they can self-ingest, they know what's going on, but it may get to the point that they can no longer swallow, that they can no longer have the strength, if they have a G-tube, to push a syringe and administer the medication that way. So that is one that, again, if you're working with somebody who's planning on using this, to, in terms of anticipatory guidance, say, hey, ingestion of this medication requires X, Y, and Z. You may lose that capacity, and while you are eligible now because you can self-administer, you may not be later. So let's move on. Okay. So I think it's worth considering why people use medical aid in dying. There's a ton of options available to folks at the end of life. Hospice, palliative care, treatment, hospitalization, voluntarily stopping eating and drinking. So one concern I know a lot of clinicians have is feeling that if people are using this, we somehow failed. We failed to control symptoms, we failed to meet some need. Like if somebody's wanting to use medical aid in dying, it must be because we're not doing something for them. So this data came from a study out of the Seattle Cancer Care Center, which looked at 255 individuals who were pursuing medical aid in dying, and they looked at why. And as you can see, the vast majority of them, it's loss of autonomy, inability to do the things that they enjoy, and these aren't things that like we as healthcare providers have remedies for. So, and also just to kind of emphasize that like medical aid in dying, it's not in lieu of expert end-of-life care and expert symptom management, it's in addition to. And then this data about who actually uses the law in terms of diagnoses comes from California. It's not the most perfect comparison to New Mexico, but it is the other largest majority minority state, and probably population-wise is more similar than like, say, Vermont. But the vast majority of people who use this law have a cancer diagnosis. So Rob talked a bit about this. So before going into like what you can do under this law, if you want to fully participate, prescribe, all of that, what you are required to do is, as Rob said, inform patients that this is a choice available to them. If you choose not to participate, inform them that you don't, and make a good faith effort to send them onward to someone who can help them pursue medical aid in dying. And again, you're not required to prescribe. You're not required to participate. And one thing I think is just worth noting is that certain organizations, FQHCs, or federally qualified health centers, I imagine, if anyone knows that term, the VA system, other federal systems like IHS, do not allow you while you are working for them on the clock to prescribe just due to federal law. So be familiar with the policy of the organization that employs you, and also know that if you choose to pursue this type of practice outside of that, that's something you can do and are legally protected to do. So this is my, you don't have to read it up here, I'll kind of summarize it briefly, my attempt at a like up-to-date style algorithm thing. So essentially, say you have a patient, they meet all of the eligibility criteria, which is that top area there. You want to prescribe to them. What you need as a nurse practitioner, and we'll just say for a patient on hospice, because as Rob said, the vast majority of patients who end up using this are on hospice. You've already had a doctor say that they have a prognosis of 6 months or less because they are on hospice. You just need a doctor, whether it is the hospice doctor or an outside doctor, to, one, document in the medical record that they have capacity to make this decision, and then attest to the fact that they are able to administer the medication to themselves. After that has been documented, you are able to prescribe to that patient as a nurse practitioner or physician assistant. Again, write the prescription. It can be filled 48 hours later. if there's concern that the patient might die before then, that can be waived. So everybody's favorite part of working in healthcare is paperwork, I know. There's fortunately not a ton of extra paperwork involved with participating with this, fortunately. There are only 2 forms, and I'll go over them briefly here. So one is you have a patient, they're eligible, you have got a doctor, so an MD or a DO, to attest to the fact that they can self-administer, that they're competent, they're on hospice, everything is good. This is a paper that the patient themselves needs to fill out, and this is within the law itself. So the patient is confirming that they understand they have a terminal illness, they have been made aware of all of their treatment options available to them, so informed consent, kind of as Rob alluded to earlier. They understand, I'm going to steal, this was from Jen Robinson, she might have said this the other day in terms of talking about reproductive health and birth control, but they can rescind their request at any time for any reason. So this is not something they are bound by, this is something that they can always change their mind. Again, this law is all about autonomy, it's all about consent. That is fluid, people change their minds. Always important to emphasize that with folks. As you can see, there's 2 witnesses that are required. No more than 1 can be a family member, and no more than 1 can be an employee or owner of a healthcare organization where the patient resides or receives services from. And the only other form is completed after somebody ingests the medication and dies. It's sent to the New Mexico Bureau of Vital Statistics. All it includes is gender, and quick shout out, I love the fact that it's not a little box, it's just like you can write in their gender. How novel. More forms should be like that. Their age at the time of death, race, ethnicity, whether they were enrolled in hospice, their underlying condition, the date of death, and I honestly don't know why this was the medication self-administered. It should always be yes. It appears like a trick question, but it should always be yes. So moving on to we've talked a lot about aid in dying medications, ingestion. What actually are these medications? So as you can see, we have a picture of a poppy, one of the largest, or the medications in the largest amount in this cocktail, so to speak, is morphine, and below foxglove, and that is from which digoxin is derived. So I also just want to point out that grams is correct and milligrams is correct. So it is not 15 milligrams, it is 15,000 milligrams of morphine. You can read this. So 100 milligrams of digoxin, a gram of diazepam, 15 grams of morphine, 8 grams of amitriptyline, and 5 grams of phenobarbital. And to prevent any risk of emesis with ingestion, people who pursue this, they pre-medicate with 8 milligrams of ondansetron and 20 milligrams of metoclopramide prior to ingestion, about half an hour to an hour beforehand. So as you might guess, this isn't something that you just enter into the EHR and send to your local Walgreens. It is a compounded medication and a powder medication, and I'll show you what it looks like here. So as of right now, for about $500 from a compounding pharmacy, you get this 4-ounce bottle of medication containing what we just went over. This is what a sample prescription would look like. And again, I'm not going to name any pharmacies that do this. There are pharmacies throughout the state whose pharmacists have been trained in preparing this medication. If you have a patient and are looking for a pharmacy, End of Life Options New Mexico can get you in contact with a pharmacy in your area and to do that. But 4-ounce bottle contains that. If you are mixing medication, one thing to know is that do not pour the powder out into a cup. This is an incredibly potent cocktail of medications. The risk is that if you pour the powder out, it can aerosolize, exposing you or other folks in the room to those medications. And given that it's I don't know exactly how much it is. It feels like it's probably 2 tablespoons-ish of powder, but the fact that it contains all that, highly potent, be very careful. So what you do is you would pour apple juice in about halfway, recap it, shake it up, fill apple juice the rest of the way at the time that the patient is planning to ingest. Don't like pre-mix it or anything like that. And when we go over resources, I will talk a bit more about it, but the organization, the American Clinicians Academy on Medical Aid in Dying, or ACAMAID, has a really great video with a nurse who works with them, Thalia DeWolf, who shows what it looks like to mix this medication. They also have, I just want to point out, great CEUs on kind of the history behind why is it this combination of medications. This isn't just like a made-up thing that was like, yeah, that seems like it'll do the trick. There was a lot of thought, a lot of evolution behind what led to this that has to do with both cost of medication as well as a few other factors. So beyond the scope of today, but just know that that information is out there on the ACAMAID, or American Clinicians Academy of Medical Aid in Dying website. So this is an actual prescription form used by a New Mexico physician who, when they, this is what they send to a pharmacy essentially. And also sending this to the pharmacy, that's what starts that 48-hour clock. So if you're sending it to a compounding pharmacy, it's always good to call after and say, hey, I sent this to start the clock, don't fill it, we're not ready for that, or call them and say, hey, please fill this as soon as you can. So it's good to like touch base with the pharmacist if you are going to be prescribing this medication, to have a relationship with them, talk with them about the circumstances, everything that's going on. So you have prescribed aid in dying medication, you have mixed it, you are at the bedside of a patient who is planning on ingesting it. Again, the biggest thing is to confirm that they still have the desire to use this medication, they understand the effect of the medication. Again, competency can change and is fluid, particularly when people are receiving high doses of opioids, benzodiazepines, other things to control symptoms. And that they can change their mind and choose another day. There's inherently pressure if like you've gone out of your way to like be present that day, family's there, everybody's there. Remind them that like, hey, if today's not the day, that is totally fine. I can come back, whatever it is. But again, this is about making sure that it is right. It probably goes without saying, but it's worth repeating. Once somebody ingests this, there is no undoing that. So be incredibly sure and have them be incredibly sure that this is what they are wanting to do in that moment. So you also want to confirm that they can drink 4 ounces of a pretty bitter tasting fluid in less than 2 minutes. So as we said, that's powdered medication is mixed with 4 ounces of apple juice. At the bottom here, median time to unconsciousness is 7 minutes. So if somebody takes 15 minutes to drink 4 ounces because they have difficulty swallowing, well, they're going to lose consciousness before they ingest the entirety of the dose, and that can be problematic. If there's concern about that, having folks practice in days beforehand, practice drinking 4 ounces of apple juice with the straw that they're planning on using, out of the cup they're planning on using, can make sure that you're set up for success at the time of ingestion. You also want to make sure that they haven't eaten or drank anything for 8 hours prior. If there's food in the stomach, particularly fats, it can hinder the rapidity of absorption and lead to, it typically doesn't lead to prolonged time to unconsciousness, but it can lead to prolonged deaths. You also want to confirm, for obvious reasons, that they don't have any bowel obstruction. And it seems kind of paradoxical, but you want them to eat small amounts in the days prior if there's somebody who just has no appetite and hasn't been eating. So if you're not eating at all, you get villus atrophy, and that can prevent rapid absorption as well. So keep the gut moving, one, and then keep it working by putting small amounts of food in. A large bore straw, I've actually used the one from Blake's once. They're pretty good and thicker. The idea is these medications, when they're mixed, they dissolve, but not perfectly. And you don't want to risk having a clumping obstruct the straw, particularly when we only have like 5 to 7 minutes before somebody loses consciousness and becomes sleepy. Yes, you can probably find a new straw, but it's going to cause a lot of anxiety for everybody there at a time when that's just not wanted or needed. So large bore straws. Sorbet, so the amitriptyline has burns. From the people I've seen ingest it, it's not too distressing. It's not comfortable, but amitriptyline is water soluble, so a spoonful of cool sorbet is one thing that is soothing, and also for family members who are there, or loved ones who are there, the gesture of like feeding a loved one something comforting at the end of life is something that everybody seems to feel good about. It's like a nice gesture. That I've seen anyway, just subjectively. And so no ice cream, again, water soluble, fat hinders absorption, sorbet is the way to go. And the median time to death is 1.5 hours. And this data is collected from ACAMADE, or the American Clinicians Academy on Medical Aid in Dying. Providers who do this a lot, they submit kind of data about how long time to unconsciousness takes, time to death takes, and they also submit data about whether the individual was on high doses of opioids beforehand, what their diagnosis was, and some of that is kind of what has gone into refining the medication protocol as well. Like I said, beyond the scope of today, but that website has great resources and like 20 plus hours of CEUs just on this, if that's something that you're interested in learning more about. So alternatives to oral ingestion, we're not going to get into the details, but if for whatever reason somebody cannot swallow medication, if they have a G-tube, they can push it through that. Again, it has to be self-administered. And then the only other option is rectal administration. ACAMADE, who I've been referring to, has a protocol on their website, but essentially what it is it would be the insertion of a Foley catheter into the rectum. The balloon is inflated, medications can be pushed that way. If that's something that you were thinking about doing with a patient, there is a lot of nuance to it, and I would recommend reaching out to some of the organizations I will talk about at the end who can get you in touch with physicians or other providers who can talk about that. So I'll let you just go through this on your own. Certain disease processes or certain conditions put people at risk for prolonged death, so you just want to be aware. Most of this has to do with rapid absorption or lack thereof of medication, so cachexia, gastroparesis, bowel edema. And again, the biggest thing I want to emphasize is waxing and waning mental capacity. It changes over time, particularly at the end of life. Make sure that the person understands the implications of this at the time of prescription, while the prescription is either on file, and definitely at the time of ingestion. So a potential case. You have a patient. I can let you read it. It's essentially somebody comes in. You had referred them to hospice. They were happy with that. You're perplexed as to why they're there. Their pain is wonderfully controlled by hospice. They have all the resources they need, but they want to die at the time of their choosing, surrounded by loved ones who will be coming into town, and like hate the idea of having others providing care for them, whatever it is. So they ask you about that, quote, death pill that they heard about on the news. Unless you're working in end-of-life care, this isn't something you're likely going to encounter often. Again, this is an important choice for many people that gives them a sense of control and autonomy, but it is not something that's for everybody, and that is great. So I don't expect you to remember all this. This is kind of a crash course introduction, but I do want to just go over some resources that are available to you should you run into a patient like that you want to work with. So the one I'll start with is End of Life Options New Mexico. They can, one, connect patients with a volunteer. I do this work and oversee other volunteers who do this work. And those volunteers can work with patients and families to help them pursue medical aid in dying, as well as explore other choices available to them at the end of life. They can also provide information to you if you are looking for a hospice in your area that prescribes. The organization could connect you with them. There are hospices who do prescribe. There are hospices who don't. I'm not going to talk about them here today, but just know that that is available and something you can be aware of. Reach out to the organization and they can connect you with them. And if you're a clinician, they can also connect you with local New Mexico clinicians who can answer questions for you. If you are interested in further training, they do clinical trainings. Email that email, and they'd be happy to get you set up for the next one. Acamade we talked about, they also have a physician consulting line. All of their language is very physician-centric because until 8-9 months ago, only physicians could prescribe this. New Mexico is the first place where nurse practitioners and others can prescribe. The physician-centric language is a little annoying, but the resources are great, so definitely check them out. Compassion and Choices has a consulting line as well. And then lastly, you can definitely reach out to me. That's my contact information. Particularly if you want to incorporate this into your practice, the biggest barrier at this point to access is lack of providers who are participating. When I work with clients, that is hands down the biggest thing that is getting in the way of them being able to get this. It's just almost kind of similar to people wanting medication for opioid use disorder. It's just providers who are willing and able to prescribe. So if you are one, definitely reach out. And then bringing it back to why we actually do the work we do, it's to work with people, to improve their qualities of life, to bring dignity as defined by them. And this quote is from the spouse of somebody who ingested medication in New Mexico within this last year. So this person wrote, "Thank you for supporting my husband during one of the most difficult times of our lives together. You helped give him the choice to die peacefully and end his suffering. Best of all, once the decision was made, he relaxed, allowing him to enjoy his last days. His goofy sense of humor returned, a beautiful gift to me." And with that, these are some references I alluded to, and want to have time for questions for either myself or Rob, who's the legal guru. So, thank you.
Does anybody have any questions? Oh, we got one right here. You want Rob or do you want Hunter? Okay.
We can share a little microphone, it's okay. Yeah.
So, as someone who works for a federally qualified health center, I was pretty sure we were not going to be allowed to do this at my employer. So my question is, if I did have a patient who was interested, is it something that I could discuss in the office? Would that be protected? And then how would I document, sort of the actual prescription and things like that? Would I have to set up something, or could I just write it on a piece of paper and put it in my glove box? I mean, how would I take care of that part?
And was the question about how you actually get a prescription to a pharmacy, or more doing it within the context of an FQHC?
I guess I'm just wondering, would it be legal for me to at least do the discussion and document, that they're competent and that they have a terminal condition, even though my employer maybe forbids my doing it? And then how do I would have to document, if I'm writing these doses of medications, clearly I would need to have it documented somewhere. Do I have to actually set up a formal, thing, or can I just write it down somewhere? How would I actually document when I do the prescription?
Yeah, that's a really good question. And let me just say that, in fact, the law is being worked out on those points because we're not absolutely positive how the law is going to turn out. But the law in New Mexico generally guides practitioners at federally funded sites in New Mexico, too. When you're looking at the standard of care is the same. The difference is that there's a federal statute that prohibits any federal money being spent on a prescription that will cause death. It's just that formal and that direct. It was designed to limit medical aid and dying and some other things too, but mainly medical aid and dying. So in fact, a federal agency cannot engage in the actual act of helping someone die under the New Mexico statute. I don't think it changes the law of informed consent at all. In fact, you still have an obligation to provide information. No one is paying for that. You have to provide the patient with the information, and then the patient gets to make the decision. And of course, you'll have to tell the patient that under federal law, you cannot provide the patient with any additional assistance, and you can't write the prescription in your role as an FQHC provider. The same is true at the VA, in the Indian Health Service, at all of the federally funded agencies. No federal dollars can be spent on this. Now, there are some people in New Mexico who interpret this to mean that you can't do anything, can't even mention medical aid in dying, but there's nothing in the law that says that. There's nothing in the federal law that says that. And again, you look back at the backup provisions, which basically say the standard of care is the same. You don't treat a patient a patient being treated at a federal facility in New Mexico is entitled to the same standard of care as somebody being treated anyplace else. And so, again, I would assume that when this all gets worked out, the conclusion will be that there is an obligation to provide informed consent, and then it's the patient's burden, perhaps with your assistant, but the patient's burden to find somebody outside of a federally funded system that will provide the prescription if that is what the patient chooses. Do you think, Hunter, is that fair? You know, it's a really good question because we don't fully know the answer yet. This is the expectation. And also, the law was written so that that would be the result. You know, you never know what's going to happen if ever somebody at the VA or someplace else decides to make a point out of it. But my own hope is that the federal law will change before that occurs, and you'll be able to do what healthcare providers in other states would do as well.
Any other questions? That was a really good one. Anybody else? All right, this is the last question. Hold on.
So I work for IHS, so my patients have IHS insurance. So for their insurance to cover this, that's a no. Is that correct?
As the cost of the medication as of right now, there's no insurance that covers it. The cost is about $500. The organization End of Life Options New Mexico does have a fund for folks who have limited financial resources. So if you run into somebody in that instance, I would direct them to End of Life Options New Mexico. And also, I will be out at the table for a little bit for folks who have other questions later and want to chat one-on-one. Since I know we are limited on time. But.
And let me just mention, because an option for many people, including some people who are otherwise covered by IHS, is Medicaid. Medicaid does not at this moment cover this care either, but it is very likely that Medicaid will. Medicaid is now working, the state Medicaid agency is working on a regulation that will allow coverage of medical aid in dying, which will open up the process in this form of care to a very large number of people in New Mexico. And again, no federal money can be spent on it. So New Mexico will not get the federal match for Medicaid used for this purpose. But there's nothing stopping New Mexico from allowing Medicaid to pay entirely with state money for this. And that is the case in at least one other state, and that will, I think everyone assumes, be the case in New Mexico, certainly in the next few months.
Good. Thank you guys so much.